चालू कर दो।
Uh, Good evening, everyone. Am I audible to everyone?
Yes.
I think it is. So, after the effective and successful first session of our webinar series on adolescent counseling in office practice, we are here again with bunch of masters to dispense the next session of series, which is well designed, advised, proposed, and convened by Dr. M.K.C. Nair sir, Dr. Preeti Galgali ma'am, and Dr. Kavita Meghani ma'am. On behalf of Chhattisgarh AHA, we extend a gracious welcome to all the esteemed guests, intellects, and participants present here. We are privileged to welcome our guest of honor for today's session, Dr. Upendra Kinjwadekar, sir, past President, Central IAP, and Dr. Yogesh Parekh, sir, Secretary General, Central IAP 2024. Yogesh, sir, will join us soon as he is traveling, so he will join us soon. Sir, Upen sir, your presence brings immense value to the session. With equal pleasure, I would like to welcome Honorable Dr. Basavaraja, Sir, President, Central IAP 2024. He is not joining us in this session. Dr. Vasan Khalekar, Sir, President-elect, Central IAP 2024. Dr. Tanu Bhadra, Sir, Treasurer, Central IAP 2024. Dr. Geeta Patil, Ma'am, she will join us soon, Chairperson, Central AHA 2024. Dr. Hema Bindu, Ma'am, Chairperson, elect, Central AHA 2024. Dr. Prakash Veer Arya, Sir, Secretary, Central AHA 2024. Dr. Ashok Mehta, Sir, National Executive Board Member, Chhattisgarh, and our chairperson for today's session. Dr. Kiran Magadal, sir, President, Chhattisgarh IAP 2024. Dr. Arun Agrawala, sir, Secretary, Chhattisgarh IAP 2024. Padma Shri Dr. Pukhraj Bafna, sir. Padma Shri Dr. A.T. Dabke, sir. Dr. Madhushri Deshpande, ma'am. Dr. Shalini Bhasin, ma'am. Dr. Atul Gupta, sir, and all the respected members present here. So, presence of all of you is a great honor and signifies the importance of our collective endeavor. We extend a gracious welcome to our today's speakers, Dr. Sreyoshi Ghosh ma'am and Dr. Swati Ghate ma'am. We are excited to delve into today's agenda with you. With the immense pleasure, I would like to request our honorable guest of honor, Dr. Upendra Kinjwadekar, sir, past President, Central IAP, and a great orator, to address the gathering with his wealth of experience and words of wisdom.
Yeah, good evening. Thank you so much for those kind words, dear Dr. Chairperson, Dr. Madhushri Deshpande, Madam, Dr. Ashok Mehta, my dear colleague from EB 2024, and of course, my co-guest of honor of this today's program, Dr. Yogesh Parekh, Dr. Kavita Meghani, Dr. Shilpa, Dr. Avinash, all the key office bearers of Chhattisgarh Adolescent Health Academy, and of course, today's star speakers, Dr. Sreyoshi Ghosh, psychiatrist, and Dr. Swati Ghate, a very dear and near friend, also a poet, a great human being who is going to address us on motivational interviewing. Padma Shri Dr. Dabke sir, Dr. Pukhraj Bafna sir, all respected dignitaries on and off the screen. It's a great honor, and thank you so much again, Dr. Kavita and Dr. Shilpa in particular, that you invited me for this program. I have attended a couple of your programs without invitation also, because we have been doing great work, and all of us, even though one may not be actively calling themselves as adolescent counselors or adolescent health specialists, no pediatrician in his lifespan can avoid an adolescent counseling session, because it is a must. So it is better to have good basic knowledge, some skill, and of course over the years one gains some experience to deal with adolescent. It's not at all easy, and what happens is everyone learns some tricks of the trade at home. Let's be very honest, that every child becomes an adolescent, and then parents, even though a pediatrician feels that he knows how to handle, but then you always get surprises. So I think it is extremely important to understand that we need to have a healthy relationship with a counselor, and of course counseling session has to be so productive. So counselor and counselee should have great understanding amongst each other, and unless and until I understand, I explore their problems, and in a friendly manner, I'm not able to provide, because we have to understand that they have to find their own solutions. We are not as counselor here to give them ready-made solutions. So even though we may not be well trained, I think what is most important quality that a counselor needs to have, a patient, unbiased, non-judgmental listening. If you cannot listen, you cannot become a counselor. You are in a hurry to make a judgment and to pass out your verdict. No, this is not law, this is not code. So this is what is, I feel, I'm not an expert in this field, but this is what I can consider. So unless and until I do that, so I need to give some psychological, emotional, and social assistance to the person sitting in front of me, that adolescent, to solve their problems. And then this can only happen once they have trust between me and them developed, so that they feel really relaxed, they're comfortable, and believe me, they're going to open up. Never ever, you may be the best in the field, never in the first session, but they are going to open up and slowly kind to understand, and you guide them to the best positive outcome. What is the ultimate aim of this counseling session? That they have to find their own solutions and they become productive human beings. I think that's the end that we should seek for this part, and I'm sure this coming session is going to guide us more on that. Thank you again. You're doing great job, the Chhattisgarh Adolescent Health Academy. And I'm sure that this goal-oriented discussion, which is going to take place using some appropriate procedures and skills that we are going to learn, and then the context in which a counselor is going to understand this point while addressing needs of an adolescent, we are going to really be benefited. Thank you so much for having this session. Thank you again for inviting me to this great session. Thank you, and our best wishes to everyone.
Thank you, sir. Thank you.
Thank you, sir, for sharing your thoughts and ideas with us. And of course, your words are very much motivational for us. And Kavita ma'am, I think Yogesh sir has not joined.
No, he will join later. Please
Can
check
we
in
move
now.
forward?
Yes, we can move forward.
Okay. So it's my distinct honor to introduce our chairpersons for today, Dr. Madhushri Deshpande ma'am. She is consultant pediatrician and adolescent advisor, Bilaspur. She is founder member of Bilaspur Academy of Pediatrics, past president, Chhattisgarh IAP 2009, master trainer of various adolescent programs of Central AHA, past president, Chhattisgarh AHA 2021, faculty in state and adolescent conferences, and contributes a lot in IAP AHA textbook of adolescent medicine, and also contributed to life skill module of Central AHA. She has 41 years of experience as general pediatrician, 15 years as adolescent advisor. She is recipient of Academic Excellence Award of Chhattisgarh IAP 2008 and recipient of gold medal for topping FCGP exam of IME. So I would like to request Dr. Madhushri Deshpande ma'am to say a few words to the gathering.
Good evening, and at first, my hearty welcome again to everyone on this platform. And I acknowledge the presence of this graceful presence of past President Dr. Upendra Kijwadekar. In absentia, I also acknowledge the presence of Dr. Basavaraja, President-elect Dr. Khalatkar, and SSG Dr. Parekh, Chairperson Dr. Geeta Madam, Chairperson AHA-elect Dr. Hima Bindu Singh, and Secretary AHA Dr. Arya, CGAP President Dr. Kiran Makhija, Secretary Dr. Arun, and EP member Dr. Ashok Mehta, Dr. MKC Nair, and Dr. Preeti Galgali. And after a power-packed academics on 23rd of June on self-counseling and effective communication by Dr. Preeti Madam and Dr. MKC Nair, we are again moving to a second and very important part of counseling, and this will be taken up by a young and talented adolescent psychiatrist and adolescent psychotherapist, Dr. Sreyoshi Ghosh. She has a very illustrious career during her undergraduate, postgraduate, and specialty training, as she was awarded with the gold medal in MD and DM course for an outstanding student. She is a recipient of various fellowship internationally, and few to are Chaving Scholarship in 2015, Helmut Reschmidt Research Seminar Fellow in 2017 at Prague, Fondizon Child Seminar Fellow in 2019 at Rome. She is at present working as a consultant, child and adolescent psychiatrist and psychotherapist. She has to her career she has to her credit lot many publications, and few important are role of telemedicine in adolescent practice in India. She, along with Dr. Preeti Galgali in 2021, and along with Dr. Swati Ghate, she has article on motivational interviewing in book on adolescent health, the adolescent friendly pediatric practice, published in 2023. She has also a publication to a credit on fat diets and in adolescent in 2023, along with Dr. Elizabeth Madam, a well-known nutritionist. Very importantly, she has undergone a motivational based therapy, and she is a co-therapist along with Dr. Anthony Beckman for persons with borderline personality disorder. With such a highly talented young budding pediatrician, she is covering a strength-based therapy, and as the name suggests, it is a positive psychotherapy and a counseling which focuses on the internal strength and the resourcefulness rather than weaknesses and failures and shortcomings. With these words, I will ask Dr. Sreyoshi for her speech. Dr. Sreyoshi, please.
Thank you so much for that very warm introduction, Madhushri ma'am, and thank you, Preeti Galgali ma'am. I mean, she's always motivating me like to write and to speak at programs like this. And I'm very happy to meet so many of you for the first time. I don't think there's as much interaction as there should be between pediatricians and psychiatrists. I'll just take a few moments to share my screen. Is the full screen showing now?
Yes, it's showing.
Okay, perfect. Thank you. Second, this control bar has come back. Yeah. So I'm going to be talking today on strength-based counseling, and I'm very happy to be here with all of you at the Adolescent Health Academy. So this is the overview of my talk. So I'll just be introducing the concept of strength-based counseling, how it has really evolved, what is the rationale for a strength-based approach, some important theoretical frameworks that revolve around this strength-based approach, and also how do we incorporate some of these concepts and aspects while we are doing our clinical assessment. So right from the first time that we interact with a child or adolescent, a few case examples from my own practice, and then finally a few concluding and take-home points. So, very simply put, strength-based counseling is an approach that focuses on identifying an individual's strengths as opposed to their weaknesses. So it seeks to empower rather than pathologize, and naturally, as a result of that, it is very collaborative and client-centric. Now, this is a concept that is very much in vogue now. So earlier on, in say the 1960s or so, there was more of a focus on traditional CBT. It was more kind of like a behaviorist paradigm that was applicable both for behavioral issues in adults as well as in children. And in fact, a lot of these were emphasized on even early on in my training, although that was not very long ago. But very traditional concepts related to operant conditioning, like reward and punishment, different kinds of reinforcements, timeouts, right? So the earlier approach was very behaviorist. So let's focus on the deficits, focus on the problems, and then administer an intervention to the child, to the adolescent. But that has been shifting now. Even CBT, in fact, has evolved. We have had waves and waves even of the traditional CBT, because the cognitive behavioral therapists have also had to keep up with the changing trends and times. And most of the current um, structured psychotherapies, including how the fourth wave of CBT is now conceptualized, looks at approaching client problems through a more collaborative sort of an approach, on not on rectifying deficits and challenges, but really looking at what are the child's strengths, assets, environmental resources, how can we leverage all of these to design treatment interventions. So it was Martin Seligman in the 1990s who very early on, he really advocated for the kind of paradigm shift that we are now seeing. He did a lot of work with regards to pessimism and optimism.
बसलाय गप्प घेऊन या.
There's some background noise. Can I request participants to mute for now, please? So, and he really looked at a lot of these, different concepts about optimism and about pessimism, and spoke about how can optimism also perhaps be learned to an extent. The same way that people often have this learned pessimism or helplessness in the face of adversity, can be shifted to a learned optimism, right? And another major figure in this strength-based approach was Donald O. Clifton, who was known as the father of strength-based therapy. And over his 50-year career, he really looked at how can we help individuals identify their strengths. He has written books on the different kinds of strengths that can be identified in individuals. And what he strongly stood for is that individuals can achieve far more when efforts are spent on reinforcing their strengths rather than highlighting their weaknesses. And certainly in adolescence, in whom it is already often a little bit difficult, to form a rapport and help them, just helping them understand and utilize their strengths can be very, very useful in forming the rapport, and then thereafter assisting them in building hope and confidence about their ability to overcome challenges. So this shift also requires some internal reframing on the, internally also in all of us. As Dr. Upendra was mentioning earlier, so, we need to check in with ourselves, how non-judgmental we are also towards, things like substance use or behavioral issues like, food, fad eating and all of that, and really do that internal recalibrating before this kind of paradigmatic shift that is being advocated can really translate into practice. Now, of course, we need to look at what is the rationale from shifting from a more behaviorist, problem-focused, let's fix this issue focus, to a strengths-based approach that is more collaborative and client-centric. Now, there is a lot of evidence that it is not exactly the type of psychotherapy that is used that is very strongly predictive of the outcome. Rather, across research, one singular factor that has emerged to predict outcome is what is the quality of the therapist-client rapport, right? And so, certainly keeping that in mind, any interview format that will foster hope, optimism, agency will better facilitate the development of rapport, and certainly the strength-based approach is one such format. And so this was studied in a little bit more detail, and there are something called a positive assessment that has been proposed by Schleiter and O'Brien that elicits information about the patient's well-being and strengths at the very outset. So this strength-based counseling, it is not exactly a structured kind of psychotherapy, like CBT or interpersonal psychotherapy or mentalization-based therapy, but it is an approach, it is a way of thinking. And so now I'm going to talk to you about which are some of the important theoretical frameworks or streams of psychotherapy that incorporate some aspects of the strengths-based approach. So certainly solution-focused therapy is the first one that comes to mind, because the primary emphasis has been to find solutions to clients' issues right at the onset rather than focusing on their problems. And two counseling techniques that the strength-based model borrows from solution-focused therapy are the miracle question and the exception situation. So, in the exception situation, the client is asked to reflect on times or moments in their lives when the problem was not occurring, right? So, for example, if the problem in question is substance use, and we are confronted with an overwhelming narrative that I am never able to remain abstinent, it is such a problem, I'm a complete failure. We ask them to really look at, so has it never happened that you have gone to a party and managed to remain abstinent, right? And we then ask them to reflect on that, those exceptions, and then really try to find out what were the circumstances, what did they do that allowed them to allow that exception to happen. So it's a focus really very strongly on what strengths they had to create that exception. Now, the miracle question basically is, so a lot of the times, clients may not know where to begin. Their lives just feel full of problems. They don't really know what a different kind of life may look like and how to really start off or create a roadmap. So the miracle question is, if you were to go to bed tonight, right? And over the course of the night, something changed and a miracle happened, and you woke up in the morning and the same set of problems that you have right now are no longer there, or this particular problem is no longer there. And the question asked to the client is, how would your life look different? Or what is the thing that you would notice that is different that allows you to know that the miracle has happened, right? So it's really breaking down, this process of change, and getting the client to reflect on what are some of these small differences that they would notice, and how can they then start working towards that. So narrative therapy is another very popular therapy approach. It was popularized by White and Epstein, if I remember correctly. And again, it is similar to solution-focused therapy, especially to the exception question part of solution-focused therapy. In that, there is an effort to help clients retell their life stories in a way that clients recall their strengths in dealing with problems rather than their weaknesses. And this particular concept that I have highlighted in bold is called unique outcome, which are the overlooked instances that contradict the problem-saturated dominant narrative. So, which again would be the moments in life when you were able to deal with these problems. How did that happen? Even when it comes to, it's very useful even when we're looking at trauma narratives, right? So if an individual is speaking about their trauma narrative from the position entirely of a victim, right? They may not be in touch with their strengths at all, but the narrative approach allows us to look again at their traumatic experiences, ask them questions like, so, but you did survive it, right? Something did get better. You're here today. What did you do at that point to stop the trauma from happening? What did you do to, get on with life? So we focus again on retelling the narrative from the standpoint of a victim to the standpoint of someone, who has some agency in their life during the time when it happened, and also in the present day. Existential therapy. So many of us would be familiar with Viktor Frankl's seminal work, Man's Search for Meaning. So again, it looks at when an individual is confronted with difficult life situations, how do we help them find meaning, find agency? How do we help them to understand that they have some ownership and responsibility in their life and life choices, and how will these life choices impact them? Gestalt therapy, it's a difficult therapeutic theoretical framework to understand. So I've just highlighted 2 points here. One thing which is definitely derived from the Gestalt approach is this paradoxical theory of change, which essentially states that the more you try to force and drive behavioral change, the less likely, in fact, it is to happen. And so, what Gestalt therapists essentially do is they focus again very strongly on the therapeutic relationship, on meeting the client in the here and now moment. They use this particular concept called field theory, which is essentially to understand the individual and his field, and so that's his environment. How has he been impacted by his environment in the past, which has shaped certain behavioral problems or certain emotional problems which he may have developed? So the focus is more on how, not on why. Like, not why do you drink? How did it start? What was going on in your life, right? And then bringing that to the here and now once again, and looking at how much of that is really relevant. Has the environment shifted? Has it changed? Has there been a change in field that allows the individual to move past certain ways of behaving and emoting that may have been relevant before? Now, when we're going for the clinical assessment, how it has been defined, how strength-based assessment has been defined, is essentially the measurement of emotional behavioral skills, competencies, and characteristics that create a sense of personal accomplishment, contribute to satisfying relationships with family members, peers, and adults, and enhances one's ability to deal with adversity and strengths. So we are looking very comprehensively at all of an individual's strengths, including not only within them, but also, their strengths in terms of which are the family relationships that are a source of support, what additional support systems do they have, how can we harness all of these. But it is not just strengths based. Certainly during the assessment, we do have to also find out what really is the problem, what is the client's perception of the problem, and so that is important. But again, it is a focus more on the strength, and how this plays out for me personally in the clinic is I usually prefer to ask children. So I know that you've come here for all of those problems which your parent has already informed me about, but we'll get to that, right? But what I also want to understand about you is what do you like to do? What are you good at? What are those qualities in you that other people have commended you for, right? Because I don't know anything about that. I only know about all of the problems, and there's more to you than that. So that also really helps in forming a solid rapport quite early on. Now, some of the questions that can be asked right in the beginning during the clinical assessment, there are a whole list of these that have been put forward by Seligman. Some of these I've put on the slide. So if there were one question that you really wanted to ask me about your problems, what would that question be? How can I be most helpful to you? What is your theory about why you have this problem? And if there were one question that you were hoping I would ask you, what would that question be? Right? So it's very reflective. It gets the person to really understand, take a very holistic approach to their problem, tries to understand what they might have already done to sort of address this. It gets them to think about where they are in the help seeking process, right? And really gets them to take charge of it rather than the clinician directing the process, which is not likely to be very, very useful. Right. So I will just quickly talk about three adolescents who came to mind while I was putting together the content of this talk. The first child is someone whom I'm still seeing in therapy. He's a 14-year-old adolescent. He presented with school refusal. So at the time when he came to me, the family were extremely anxious. The child himself was very, very disturbed. He had been several attempts had been made to send him to school. Different kinds of methods were being used by different counselors in the family. He would just go to the school gate and then he would just start shouting. I mean, he was that anxious and they would just have to bring him back home. And the family came to me with the request that, I mean, you do whatever you can, but we need him to go. Now, what I kind of realized early on is that if I kind of make school refusal the problem and I sort of, you know, just look at, okay, let's do a graded exposure to school, let's send him for 1 hour, give him some reward, that this is really not going to work. So, we had to sort of flip it around. We did not make school refusal the main issue that we would talk about in therapy. We would look at how this problem developed, so he had several instances of trauma. I'm not going into all of the details in the school setting, which had involved very public, feelings of shame and humiliation. So we spoke about that. We tried to see what he could do to tackle his social anxiety. He did not go back to school for 2 years. He finished his ninth and 10th through National Institute of Open Schooling, and he did really well. I was very happy when he came to me 10 days ago saying he's got 92%. And now he's rejoined PU and he is going to college. And so it was, really sort of empowering this kid to, and by looking at his strengths, the fact that he is very persistent, he wanted to keep studying, he wanted to, do well. And, we did all of that with a focus on the problems that um, um, were arising to prevent him from going to school in the first place. And it took a lot of time before he's kind of been able to overcome some of it. This second child, so I had seen her while I was doing my DM at NIMHANS, and she presented with nocturnal enuresis and also with non-suicidal self-injury, that is, again, cutting. And I remember the parents were very distressed and they just wanted it to stop. They just wanted her to stop cutting. And this kid would not say anything to me. She would just say, I don't know, I cut, when I feel bored. Yeah, I'll stop. If you tell me to stop, I'll stop. And back then, I think I was also much more behaviorist, in my approach. So I would try to, I remember initially sort of be, like very, like, how many times did it happen? And, what was the consequence of it? What did you feel? And that really wasn't working. It wasn't working. So then we kind of shifted focus and, we looked at what else is happening in her life. What are the other stresses that she's going through? And so a lot of conflicted family dynamics emerged. So especially a lot of pressure from her father with regards to academics. And she would feel very upset when she felt that she has not done as well as he expected. So he himself was very high achieving. He's gone to the IITs and he expected her also to follow in the same path, but that was not what she wanted to do. This was a kid who was very smart, empathetic, loves nature, love to sort of help people, and she wanted to become a lawyer. So even without her father really being very aware that mm, that she is sort of finding her sense of self and shifting focus away from his IIT dreams to more, where her strengths and where her interests lay. That did happen, but that was very empowering for her. And we also did a lot of attachment focused work with her and her mother, who was really able to understand her point of view. And that became a strength, that attachment relationship between her and her mother. And what finally happened was that, she finished school, the enuresis and the self-cutting, that just resolved as her self-esteem grew. And she is now in law school, and she's doing really well. And this last child, she is a 13-year-old adolescent. She is an adopted child, and she presented with primarily scholastic issues and ADHD. And her mother was very, is still quite anxious, wanted her to do well, because this is a kid who otherwise is, quite street smart. She's quite bright. So her mother could not understand, like why she's not studying. And so it required a lot of, and the kid was very resistant to even trying out methylphenidate. She felt that her mother is kind of forcing her to come to us, and that we are also going to force her to study. So it required a very sort of collaborative approach to kind of really reach her and understand, okay, what does she want from her life? And she wants to dance. She's a fantastic Kathak dancer. So we kind of worked with that, and we said, okay, we're going to support you 100% in that, but do you kind of want to get through school, and can we just help you get through school, right? So that you can after that just pursue your dreams. And so we've kind of reached this balance where she uses methylphenidate actually for just a short duration of time in the day, just to get her work done. And then she's out playing, she's very good at athletics, she's dancing, and that time her mother has just learned to sort of let her breathe and let her have that space. And it was really sort of building that rapport with her, understanding what she wants, what her strengths and interests are, that helped things to move forward with this child and her mother. So just to conclude, once again, the strength-based intervention approach focuses on the patient's attributes that promote wellness, and it can work synergistically with the conventional medical model of treating disease. So like I was discussing earlier, it is not that we did not help the last child, Miss A, with her academics and with her inattention, but the approach definitely did incorporate a strong strength-based focus. And this approach is predicated on the assumption that each individual has a unique set of goals and possesses internal strengths and also external resources, like family relationships, etc., that can help them achieve these goals. And so ultimately, it aims to activate a patient's hopefulness. I would prefer to say maybe a client's hopefulness through a strengthened relationship with himself or herself, their family, therapeutic supports, community, and culture. Thank you. That brings me to the end of my talk. So I'll just stop screen sharing.
Thank you, ma'am, for such a mind-blowing and engrossing session. Definitely, it will help all of us to see this approach of strength-based counseling. And we are very fortunate to have with us Dr. Yogesh Parikh, sir, Secretary, Central IAP 2024, who, as a guest of honor for today's event, he has joined the meeting. He is a distinguished man who made remarkable strides in the field of pediatrics. His vision and leadership has inspired many of us to strive for excellence and compassion in our field. So please give a warm welcome to Dr. Yogesh Parikh, sir, our guest of honor, and as he would address us with his valuable perspectives. Sir, are you here?
I saw him online. I think now I am not seeing him.
Sir, I have also seen. I have also seen him actually.
Yeah.
He has actually, he's at airport and he's a network issue. Let me call him once, just 1 second.
I think till then you can take the question answers.
Yeah.
The question answers will be taken after another.
I think in the
session.
meantime, madam, you can take a couple of questions and then we
Okay.
will manage later on.
Okay.
Madhushi ma'am, are you going to take some questions from chat box?
If the
or-
time permits, I will take the questions. Otherwise, after the session, next session also we can take.
कणिकर सर ने एक बहुत अहम सवाल पूछा है, वो देखिए.
Yes.
Sir is not receiving the phone. Probably he's in. Actually, there's a lot of crowd over there, and network issue. He's on airport.
So,
So we can, I think,
so
continue.
respected
Send a
students,
message
can we
also.
move on?
Move
Can
on
we
for
move
the
on?
next session.
Please.
Okay.
Yes, yes.
And we will take question answers
Question answers later
later.
on. Later on after that.
So after this session, we are moving ahead to next session, and for this we are honored to have with us Dr. Ashok Mehta sir as chairperson for this next session. He is a National Executive Board member, past president CGIAP 2022, and a renowned and ingenious pediatrician from Bilaspur with extensive expertise. And we are eager to hear from sir a few words of wisdom. And may I request him after that to introduce our next speaker. Sir, please.
Thanks, Shilpa. Thank you very much for giving me an opportunity to chair an important session by Dr. Swati Ghate. I think we all met her in our Durg conference last time when she had taken a workshop at Durg. She's a pediatrician and adolescent health specialist and a clinical psychologist and joint director of Babylon's Newton, Jaipur. She has been a very active member of Adolescent Academy, and she has been a Northern executive body member. She has been a national coordinator of scientific committee in 2022, member of scientific committee in 24 also. She is convener of CIP Task Force 2021 to continuous 3 years on school reopening and remote learning. We all remember it was a COVID time, and there was a lot of discussion how to reopen the school and how to control TV watching, still learning and all that. And she has been a coordinator of DIP webinar series for parents and teacher in 2020. She has been co-author of IIP obesity guidelines, and she has been associate section and academic editor in AHA IIP textbook on adolescent friendly pediatric practice, IIP AHA textbook of adolescent medicine and teachers module. She has been contributed to many such more publications. I would not go in detail and will not come in the way between her deliberation and you. Over to you, Swati madam.
I would add here, she is a very good, she has published a book on ghazals, and she is a very good poet and an author to many books in Marathi and other things.
Good, good. Nice to know that.
Thank you so much. for those-
Multifaceted lady.
Oh my God. Thank you so much for those kind words. And good afternoon to one and all. And my respectful regards to all the seniors present here. May I share the screen?
Yes.
Sure.
So
Before you start, I welcome Dr. Geeta madam. She is on the platform.
thank you. So are you able to see my screen?
Yes.
मॅडम फुल स्क्रीनचा अजून फुल
हाँ,
स्क्रीन
हाँ,
नाहीये.
हाँ. Full screen there. येत आहे?
Yeah, perfect.
So after that fantastic talk from Dr. Sreyoshi, let us now learn about motivational interviewing in the context of substance abuse in adolescents. The slides are not moving. So we will see what are the stages of changes in behavior, what is MI, how does it, how it is carried out, what are the strengths and weaknesses, and we also will consider a counseling scenario at the end. We will not touch upon substance abuse per se because it is a very different topic altogether. So motivation, as we all know, is the driving force that takes us to success. right? So many of us and most of us are wanting to change something in our behavior, and then we are not, we are into different types of thought processes, and these are called stages of changes as given by Prochaska and De Clemente, which are pre-contemplation, contemplation, preparation, action, maintenance. And if the maintenance slips, then there is a relapse. So we know that adolescents have to really, a tendency to indulge into risk-taking behaviors, and what the behavioral pattern that they set in the adolescent age will last for life. So it becomes very important for us to train adolescents for taking good behavioral changes and making them lead a productive and healthy life, not just today, but also in future. So these are the changes. This is the cycle of change. Let us see what it stands for. So in the pre-contemplation state, there is no realization that the behavior indulged is causing any harm. Maybe, yes, I'm taking alcohol, and so what? It is that attitude is there. In the contemplation stage, there is some insight into the issues that that alcohol might give rise to, like probably it will cause some harm to me, and it is not making me play as energetically as I should be playing. Then there is a stage of preparation, wherein there is a determination and a sort of a real thought to think about change and give a some planning to it. So there is this, yes, I need to cut down, but probably I will cut down on a daily basis. I'll cut down a peg or so, whatever. And then action, it is this. Yes, the adolescent now cuts down on the alcohol as he has decided. Then he stabilizes in the maintenance phase, but yes, something goes wrong, and then he is likely to go back and relapse and again start consuming alcohol. So we all go through such stages, whether it is cutting on our diet, calorie, cutting on our mobile use, getting up early in the morning, and all those things. So this behavioral change and the motivational interviewing is a very useful technique for all of us, not only the adolescents, but it is very, very adolescent friendly. So these are the 6 stages we have just seen. And why this is so adolescent friendly? Because we have seen that there are many types of approaches, as Dr. Sreyoshi was also telling, that there are certain approaches which are very, very systematic and very, very demanding for the adolescent, like the CBT. It involves a lot of cooperation. It needs a lot of cooperation from the adolescent side. He has to do the assignments, he has homeworks, he has to change his thought processes like REBT and all those things. So it needs a lot of input from his side. So many adolescents who are brought to us in their office, they are not so willing to take up the change, and they are not willing to cooperate also. So for such people, such adolescents, this motivational counseling is a very good choice. Most importantly, it gives a lot of autonomy to the client. The counselor is not dictating what to do. It is the counselee who decides what he will be doing. And this autonomy is something which our adolescents are very fond of. So they accept this type of counseling in a very positive way. So there is no skill building, and there is no information sharing, unwanted information. Alcohol will cause you liver damage and all those things. We are not talking in MI about all these things unasked for. And also an MI counselor is absolutely non-judgmental, and there is no labeling. So motivational interviewing is a collaborative conversation style where we strengthen the person's own motivation and his desire and commitment for a behavioral change. The main aim is to shift from the extrinsic motivation to his intrinsic motivation. There are so many studies which I've already elaborated that howsoever times you may tell the people to change their behavior, unless they are motivated from within, it will not happen. So the MI exactly takes into this consideration and focuses on the intrinsic motivation. This style of counseling was proposed by Bill Miller and Stephen Rolnick in 1980s, and it is based on Carl Rogers' humanistic theory, which is a person-centered theory. This Rogerian theory says that the client should be at the center stage. He has lot of capacities and abilities, and he can take care of his life. He can change for better by himself. But if he finds a counselor who is genuinely interested in him, he's warm and expresses unconditional positive regard for the counselor, the counselee himself is able to work for himself and for his betterment. So this is the crux behind the motivational interviewing. It is focuses on the language of change. The actually counseling, which is a talk therapy, it involves a lot of talking from the counselee, and the counselor looks for the language of change, and he strengthens the personal motivation of the client, which is there. He just discovers it, he uncovers it, he digs it out. It is already there. It is assumed that it is already there. I'm not going to imbibe some motivation in him. It is already there. And what is the language of change that the client is talking? You have to just focus on that and take it ahead, take a thread ahead and move ahead so that the desirable change is obtained. So the motivational interviewing has many dimensions to it. So the main spirit of motivation interviewing is giving full autonomy to the client. He is master of his own life. You are no one to dictate. Secondly, you have to make a collaboration. That is, you have to make a friendship with him. You don't have to take a stance that I am someone superior and you are someone who is subordinate to me, or I am the preacher and you are the listener. Third is the evocation. That is bringing out. Just now we saw bringing out what is lying hidden inside the client, which is good for his motivation to change for betterment. Then there are certain principles. These principles, we will come see it later again. There is first and foremost is expressing empathy. We have listened in the last lecture also that empathy is very, very fundamental to every counseling session and in every type of counseling. Then rolling with resistance. For any behavioral change, resistance is a part of that process. We ourselves have also experienced so many resistances within ourselves when we contemplate a change. So the resistance should not be argued upon, and you should just allow the client to show his resistance and move ahead, give him time to change and not press him or push him hard. Then the third is developing discrepancy. This is very important. This we will see in the slide when we'll come to it. And supporting self-efficacy. That means supporting his own idea that, yes, I can do it. So with all these principles, the counselor applies his own micro skills, that is skills which are needed in excellent skills of communication with open-ended questions. This also we have seen last time. Affirmation, that is appreciating the good that he is doing, appreciating his qualities. Reflections, that is telling, like rephrasing what the client has already told in a manner that probably also elaborates the hidden meaning or hidden feelings of the client, which he cannot explicitly speak up. And then summarizing so that you know that they are on the one page. So with these micro skills, when the dialogue goes on, then the change talk appears. This change talk is about desires. The client says, I wish I should cut down on smoking. Then his abilities, his reasons to change, his needs to change. And then comes the commitment of intention, action, and activation. So thus the behavioral change is brought about by taking into consideration various strengths of and various dimensions of motivational interviewing. And this is a very fascinating journey. So the spirits of MI the acronym PACE stands for it. We have seen that it is building up a partnership or a collaboration and giving him full power to control his life and not being an intruder. Accepting unconditionally whatever he is. Okay, he is a gambler. You have to accept that, yes, he is a gambler and not be critical about it. Also, you have to give him complete autonomy and when and how the client wants to change his life. We cannot like tell him that from tomorrow you don't drink. That is not being a MI counselor. So when something is going wrong in someone's life, we have pity, that we acknowledge the feeling of that person. Sympathy is when you care for him. Empathy is you feel the same sorrowness, same low feeling, same depressive thoughts you feel for that person. And compassion is when you want to relieve the suffering of the next person. And till this type of engagement, optimum and a very deep engagement is not established within the counselee and the counselor, MI cannot progress. So, fourth is the evocation, wherein we make the counselee articulate his values, his goals, his ideas, his what is going on in his life, and then bring about how this behavior in question is very, very deviant from what he wants to do and what are his values and goals. And then we gently make him understand that this is the discrepancy, and then he is motivated to change as he gets to know that, yes, something wrong is going on in my life at present and the life I want to live. So expressing empathy, we have seen. Developing discrepancy is the same that I was telling you, that inconsistencies between current behavior and goals and values, communicating them in a very gentle, non-threatening manner, offering information regarding the consequences only if he is willing, not bombarding him with information that all these substances are so bad, your brain is developing, you are now learning, you have to do your academics and you are like wasting your time, and all those things are not at all a part of MI. And that way we avoid argumentation and stand different from the parents because they are always doing the same at home, and we have to be really very different. Rolling with resistance means recognizing that there will be something which the patient wants to be in status quo. And self-efficacy, that is person's own belief that he can do a change and he can move ahead, that you have to imbibe in him. So we have to give him a lot of confidence. We have to really feel a sense that yes, he can accomplish, and also look ahead with optimism in his life. Accepting and expressing that change is a slow process is also very essential, because people have shown that for 2 years or so, the people like the change does not happen. Pre-contemplation stage to contemplation stage can also take months or years together. But really, we have to keep patience. And if it is a failure, we have to really look into our own strength, our own capacities as the counselor. So the micro skills of communication are open-ended questions for elaborating whatever the counselee is going through, appreciating his strengths and abilities, rephrasing and paraphrasing about what he has told, and summarizing so that we are on one page. These are effective communication skills which are very, very essential for going ahead in this MI. So here comes the ORs, and the things that are written in red are the things that we should not be using. These are the wrong statements. You do agree that drinking has a detrimental impact on health, right? So this is a very, very close-ended question and should not be put. Instead, we can ask, can you tell me about the impact of drinking on your life? Then I really appreciate you are being so honest with me. This is an affirmation of his strength to open the truth. You're disappointed and upset when you miss out on sports because of your drinking, and you wish to do better. Probably you wish to do better is not something which is spoken by the counselee, but it is something that you have brought about so that he is motivated for a change. And this is reflecting the true inner feeling of the counselee. I understand that this behavior has become a cause of your underperformance in sports, which you wish to improve. This is the summarization of what all he has been telling and you have been understanding. So this way, ORs keep us helping in all our communication and making things clear between the two of us. The processes of MI are same, like engaging, rapport building, and trust building. Focusing, that is prioritizing what is the agenda for now, evoking, encouraging the patient to talk, and then the sustained talk will be converted to change talk, and that you have to bring about. Sustained talk means the same thing that he wants a status quo. I'm just smoking once in a while and I don't do any other thing. So it's okay if I smoke. So I do not do exercises, but then I keep my, I keep control on my eating. So this is a sustained talk. From that, you have to come to a change talk. He has to come to a change talk, and these change talks have to be evoked by gently giving him the discrepancies. So next stage would be obviously planning to make the change. So there are two phases in MI. First one is the building motivation for change, and second is strengthening the commitment to change. There are various strategies with which we help our clients to undergo and move ahead through these phases. So first and foremost is eliciting self-motivational statements. For that, you need a lot of narration from the counselor's side. So we have to put in many questions. What do you like about your drinking? What is positive about your drinking? And what is the other side of it? What are your worries about drinking? So when he elaborates, then only we can get to know where he stands and what are his views as of now, so that you can change them for better. And this type of red sentence, you must stop drinking because you're performing low, are a big no-no. Listening with empathy, we have already seen. Gathering more and more information. How much do you drink? This is a bad question. Would you tell me how is your typical weekend? This is a better question, because how much do you drink appears very offending to him. So then whatever good he is doing, judiciously praising it, right? Just now we saw that the positive psychology is very much in vogue, and that this is also very, very important. But the praising should be judicious. You cannot go on praising every now and then and for every little thing, so that the client thinks that, yes, this is not coming from the heart. Handling resistance is very important. So when the client is showing resistance, he will be in a denial mode. He will belittle the problem. Kya hua? Thoda sa hi to hai. He will argue. He will interrupt what you are saying. He will sidetrack the conversation. He may miss the appointments, or he may arrive late. And this way he shows the resistance. But MI theory says that the reason for resistance is the counselor's faulty confrontational or directive style, and it is not the attribute of the person. Because again, the positive psychology, we believe a lot in the counselee. We know that he is a great person who helps himself, who is ready to help himself, but what he needs is just discovering himself. That is what we are here for. Rolling. So reframing the problem positively so that the client feels the need to change. Now look at this sentence. So you do not want to disturb your parents with your personal problems, and so you drink. But then they are disturbed by your drinking. So this is how you make him realize that what he is doing is something which is not compatible with his goals and with his feelings. Then comes the providing relevant information. For this, the strategy used is ASA, ask, share, ask. You have to first ask, do you want me to tell you how cigarette smoking is bad for health? Then share the information. If he says yes, because most of the people will not be in a mood to listen, many of them might be knowing. So you need to know what exactly to share and refrain from bombarding with information. So striking the decision balance is very, very important. Now, as you highlighted the pros of the changed behavior, the reason for change should outweigh the reasons for status quo. And this is what the aim of the MI is. So you can make a decisional balance card like this, where the adopting new behavior will show its pros and cons, and staying status quo will show its pros and cons. And then probably he gets some idea as to what is good and bad. Finally, summarizing. Then when he is ready to change, now it comes to strengthening his commitment for change. First is recognizing whether a client is ready or not. So how we will identify the client is ready? He will ask fewer questions. He will appear settled and calm, and he will not give any resistance to what you are saying. He will be right sort of a cooperative, and most importantly, the change talks will appear. He would say probably, I think I should cut down on my drinking. Now that you have enlightened and highlighted so much of pros of the changed behavior, The change talks could be identified by this acronym DAN-CAT. These talks tell us the desires, abilities, reasons, needs for change. I wish to cut down my alcohol. I can get up early in the morning and go for walking. I should cut down my smoking because my teeth are staining. I need to quit alcohol because my mom gets really mad. These are some of the change talk the counselor is eager to hear. So then there comes commitment, like I'm going to join a gym. Activation, I'm ready to give away with my friends who are smoking. And then taking actions, which he tells you, that, yes, I didn't smoke the last week. So these are the talks which we should just pick up and use them to move the things ahead. So once these talks have appeared, what next we do is put up the scaling questions. On a scale of 0 to 10, where 0 is least and the 10 is the most suitable thing, where are you regarding the importance of this change, the readiness of this change, your ability of this change? So the client then gives you an answer. So if he says that, yes, I'm at 3. So why you are at 3 and not at 0? So you get to know what he has already given some thought to it, and what is the thought process. Then you may ask him, what can we do to take it from 3 to say 4? And in this way, the scalings could be graded upwards, and a fully charged person will be in front of you who is ready to change. But for that, you need to be very, very gentle and not at all a coercive style of communication, and from within your heart, you should feel that I have to help this person. So when the change talks appear, we affirm them with reinforcement and encouragements, and also elicit detailing. In what way you are going to do that? How you are going to do that? And next step is planning. So now comes the action, shifting from reasons to change to action plans. The bad sentence would be, from tomorrow, you can take only 1 cigarette every day. This is not MI. What are the possible ways to cut down? You only give him a chance to think and take out his own solutions. So free choices should be given to him, and it is him who is responsible for the change. We are not at all responsible. And you have to, in fact, say that it's totally up to you as to how and when you want to go about this plan. There is no taking hold of the life of the counselee. It is his life, let him do. So though the plans are sort of combined plans, but yes, the responsibility lies within the counselee. So then discussing consequences of action and inaction makes sense, so that he can he is little ready and he can predict what is going to happen in his life. Then sharing a worksheet on planning is also very, very important. We'll see it, and supporting to continue the change. So this is the worksheet which we can probably share with him. The change I want to make, the changes I want to make are, probably he will write, I want to cut down on smoking. The most important reason to make this change, I want to do good in sports. The specific step that I can plan for making this change, I can probably purchase less number of cigarettes. Who can support me? My mother. How he can support me? She will give me less pocket money. How I will know that my plan is working? When my coach will say that, yes, you have performed better than last month. So things that could interfere in my plan, barriers would be my friends who call me for smoking along with them. And what is the possible solution? I will say the skills of learning no. So this is how the change plan would be complete, so that the client feels empowered to move ahead. So this is how the MI thing goes. So there are many areas of application. To our importance are not only the physical health, including the lifestyle diseases or treatment compliance in chronic disorders, addictive behaviors, gambling and substance abuse, but also academics and parenting approaches. They have also been shown to be they have shown to be helped through MI techniques. So the pros of the MI technique, we are already seeing most of them. It is less time consuming. I think someone is, I think there is a.
Mallika madam, please unmute yourself, mute yourself.
So it is less time consuming. 4 MI sessions are equal to 12 CBT sessions or Alcoholic Anonymous sessions. For clinicians, it is a very good learning tool for their own communication skills. It builds a very good relationship with the clients and the patients, and there is better compliance, and thus it is very, very rewarding. Of course, there are a few disadvantages which are that MI needs proper training. This stance that we have already imbibed in ourselves as experts, please try to mute those who are speaking. So we are, as clinicians and counselors, we always know, like we always think that we are experts, and to treat clients as equals and friends is very, very difficult. So this mindset is very, very difficult to imbibe. Then MI probably is not very useful for those who are under 12 and for those who are suffering from severe mental disorders like depression and suicidality. With this, we will move ahead for a case scenario. Rohan is 16 years. He was brought by his mother. She is worried and wants him to quit smoking, which he is not considering. So initial steps of rapport building, privacy, confidentiality, as we do in all adolescent office practice, they were all carried out. His general examination was done. Headesses for knowing strengths, weaknesses, his environment, his aspirations, likes, dislikes was all done. Then this SBIRT speed tool was applied to him. We will come to that. And to know which stage of change the adolescent is on, and is he confident enough to embark on his journey of change. So what were the findings? On Headesses, the important findings were he is very much attached to his mother. Eating he has poor appetite and he's worried for his weight. Activities, he roams around with his senior friends of basketball club, and he loves music. He has been smoking 2 to 3 cigarettes per week since last 1 month, but there is no other substance abuse. There is no suicidality, no low mood, and there is nothing more significant in this Headesses. So coming to this tool. So this is a tool which tells us about, which is a screen to behavior intervention approach, wherein we are supposed to screen every adolescent that walks into our office. We have to ask him this question. In the past year, how many times have you used tobacco, alcohol, or marijuana? So if there is no use, then you have to positively reinforce the child and move ahead and ask the same question in his next visit. If he says that once or twice, then it is probably an experimental indulgence. There is no substance use disorder, and you have to give him a brief advice. But before that, you also have to ask whether he has used any prescription drugs, any illegal drugs, any inhalants, herbs, or synthetic drugs. Now, if the use is monthly, then we call it a mild or moderate SUD. For that, we need motivational interviewing, assess for the problems, advise to quit, make a plan, and reduce the use and risky behavior. If the use is weekly, that if he says that, yes, I have been using any of these things on a weekly basis, then he is in severe SUD, where again you have to ask for other illicit drug use and give a motivational intervention and also a referral to treatment. So this is the SPIRIT tool, screening, brief intervention, and referral to treatment for higher center. So this is done in all our office practice cases. So most of them will be no substance use, will be positively reinforced. So though some will be given very brief advice for their intelligence. Those who are into mild or moderate use, they will be given motivational interviewing, and those who are into severe SUD will be referred to psychiatrics. So for Rohit, the impression was he has moderate substance abuse. He is in the pre-contemplation stage. The intervention strategy planned was motivational interviewing. So when the motivational interviewing we start, there are various stages as we have discussed, and the tasks for the MI counselor are different and they vary as per the stage. So now, with your permission, I invite my friend and dear colleague, Dr. Shikha. Shikha, are you there?
Yes, ma'am. A very
Yeah.
good evening to all.
So let us now present this case scenario and how the MI was conducted in this particular patient. Whatever I have written here in the orange are the strategies that we have followed. Right? Like O is for open-ended question, R is for reflection, what the client wants to say. Then A is for affirmation, that is praising the child. Then SS is for like supporting self-efficacy. ASA is for ask, share, ask strategy. That all we have seen. So Shikha, are you ready? Shikha will play Rohan and I'll play a counselor.
Yes, just bear with the boys' voice.
It's okay. Right, Priti madam, shall we go ahead?
Okay, it will be a few more minutes. Is
Yes.
everybody agreeable?
Yeah, madam. Yeah. Let them.
Yeah. So this will be real fun. So go ahead, Swati.
Right. Thank
Chika,
you.
open your video also.
Yes, ma'am. I'm here.
Okay, welcome.
Okay.
Thank you.
So, Rohan, what makes you smoke?
Oh, smoking is pretty cool, doctor, and it makes me feel connected with my friends.
Oh, just a minute. There is something has gone wrong and I'm not able to see my screen. So what can be done for that? Okay. I hope this works. Oh, that's good. So you love being with your friends. What else you do when you are together? Can you think of some more ways of connecting with your friends?
We play basketball or just roam around, doctor.
Great. Playing is fun. It is more enjoyable when you have good stamina.
Oh, but I don't want to quit smoking.
Perfectly fine. It's your body and it's your decision. Do let me know if ever you think otherwise. If you wish, I can share with you how reducing just 1 cigarette a day helps.
Let me think about it. I shall get back to you on that. Thank you.
Right. So this was on the pre-contemplation stage. Now coming to the contemplation stage. Yes, Rohan, welcome.
Thank you, doctor. Sometimes I feel I should reduce on my smoking now.
Oh, that's fantastic. What makes you think so?
My mother doesn't like that.
You said your mother doesn't approve of your smoking. And I'm sure you love and respect your mom.
Yes, I do. But then I don't know.
What stops you from cutting down on your smoking?
Oh, doctor, I can't live without it. Smoking is great solace. Moreover, I shall feel left out with my friends if I don't smoke.
You said smoking makes you feel relaxed and connected with your friends. I understand that you must be wanting to feel at ease.
Yes, doctor.
But then probably you feel guilty too for offending your mom.
Yes, very true, doctor.
That keeps you oscillating in two minds. On one side is your mom, your body, your health, and your future. On the other are your friends who may not be with you the next year.
But they are my best friends, doctor. I can't leave them.
That's okay. Think about your priorities and let us meet next week. I'm sure you'll take the right decision.
Sure, doctor. I shall give it a thought. Thank you.
Rohan comes next week in the stage of preparation.
Good morning, doctor. I tried hard to quit smoking,
Oh, that's so nice.
but I got so restless and agitated that I had to ultimately smoke again.
Your efforts to help yourself are praiseworthy, Rohan.
Thank you, doctor.
But probably we need to go more systematically to be successful.
I know, doctor, but I don't know how to do that.
Would you like to know some ways that people try and succeed?
Sure, doctor. I think that would help.
So people cut down on the smoking step by step.
But it seems so hard. It's almost impossible.
They start with reducing the number of cigarettes they smoke each day, or they just throw away the cigarette halfway.
Oh, that sounds interesting and good.
So you may give a thought on trying these things.
But then what do I do when I get restless?
How about listening to music or playing with your sister? You may choose some of those things which you find suitable to relax.
That's a good idea, doctor. I shall try these things and come back to you.
Right. So then was the maintenance phase when Rohan was back again.
Oh, doctor, good morning. I have a good news. I didn't had a cigarette in last 1 week.
Oh, hearty congratulations. So you could do that. That is highly creditable.
Yes, it is. But I do miss all the fun with my friends.
I agree. When you leave behind something you are associated with for quite some time, it pops up in your mind every now and then.
Yes, and it really hurts.
That's exactly the time to remember to reward yourself for what you have been done successfully till now.
Oh, what kind of reward you are referring to, doctor?
So you are sober for a while. For that, you may pat yourself, say a positive self-statement of appreciation, give yourself a treat, or share it with your mom.
But how will that help me?
That will make you adhere to your plans. Soon, your appetite and stamina will increase. You'll play better and win matches.
Okay, it was a good talk, doctor. I shall come back to you after some time.
So after some time, Rohan is back. But
Good
now,
afternoon, Dr. Swati.
good afternoon.
I am ashamed to tell you that I smoked yesterday and I am very sad about it.
Oh, good that you shared with me. Such slips are known to happen. They are to be picked up at the earliest and taken with a stride.
But I am afraid I may start smoking again.
I understand your concerns. That will happen only if you are too strict on yourself.
How?
Rohan, it's okay if you allow yourself to err once in a while. To err is human. Be kind to yourself.
But how will that be helpful? I want to know that.
It's not the slip per se that leads to relapse, Rohan. It is the negative thoughts around the slip that give you a sense of failure. This stress and sense of failure then pushes back to the undesired behavior.
Oh, I see.
So it's good to be cool, yet careful. After a slip, one should immediately take hold of oneself. How can you help yourself in this situation?
I shall try to forget my slip and move ahead.
There you are. Your determination will bounce you back to your mission. What else can be done to stop such mishaps in future?
I think I shall throw away my remaining cigarettes and the ashtray. And I shall keep my mom's photo on the table. That should help.
That's quite interesting. You may also keep your photo in your sports attire.
That's quite interesting, doctor. I shall try all that and thank you for all your help.
Bye, Rohan.
Thank you, doctor.
So, thank you so much. With all these spirits, we tried to elaborate this case of Rohan. And coming to the take-home messages. So we have to be partner and not the expert. Resist the writing reflex. We have this tendency, inherent tendency to fix what is wrong. And this is writing reflex is, we are not resorting to this reflex in MI. Listen empathetically, understand and respect clients' thoughts, avoid accusation and argumentation, identify and highlight discrepancies between behavior and goals and values, expect ambivalence, recognize and support the change talk, support and promote ability to change, let the client take the decision, and important of all, don't feel guilty about not being able to bring about change. It's his job and you are just a facilitator. So these are the references, and I end with a big thank you to one and all, Dr. Preeti Madam, all the organizers, Shikha Madam, and this quote, your life does not get better by chance, it gets better by change. Thank you so much.
Thank you very much, Swati Madam, for an excellent talk. And on a lighter note, when we used to smoke and quit someday, and we used to talk, it is easiest to quit smoking. You can quit it every day.
That's fantastic. That is fantastic.
We did quit. Sometimes we add a point, when the cardiologist told me, one cigarette once or sometimes, daily or occasionally, has got detrimental effects on your heart and your blood pressure. And if you've got a family history of cardiac or BP thing, refrain from smoking. This is what I tell my patients. And that works. Because smoking and tobacco are absolutely unfriendly to the cardiac health of any human being. This is what point we add to our counseling, whatever counseling we come across. So it was an excellent session, and congratulations for an excellent talk.
Thank you so much for your kind words.
Ashok sir, may I make one comment?
Yes, sir.
Yeah, thank you. It was brilliant, Dr. Swati. In fact, thank you so much, AHS Chhattisgarh, for inviting a wonderful Sunday spent. I can see Dr. Geeta Patil over here. Madam, this last counseling session which Dr. Swati conducted, I think it can be clipped, recorded, and could be shared with everyone. That's actually practical, and this is how the discussion takes place, and the way it was 1, 2, 3, 4.
Yes, sir.
Share with all our colleagues. It would be wonderful.
Yes, sir. Yes, sir.
It's a practical demonstration of how, without sounding offending, without preaching anytime, it was brilliant. So this is the way it has to happen. Thank you so much. Thank you.
Thank you. Thanks
Sorry to interrupt. We can add on our YouTube, Swati. And Swati, as
Yes.
usual, you are excellent.
Thank you,
Yes.
madam. Thank you so much.
I'll just quickly respond to what Dr. Ashok Mehta said. Sir, your points are well taken. When it comes to adolescents, usually they don't have consequential thinking. They can't think so far as the heart attack. So what Swati has done is she has focused on immediate consequences like the effect on sports and on the effect on his relationship with the mother. So I think another important counseling point to consider when talking to adolescents, focus on immediate consequences rather than the later ones, and the later consequences can be discussed with late adolescents and young adults. So I wish everybody focuses on, they will say, I'm going to stop smoking in another 5 years, doctor. I'm not going to get a heart attack. I'm 15 now. You say heart attack at 30. I'm going to be stopping that. So that is how they reply, so that's just a point to consider.
Dr. Ashok Mehta was talking in reference to the medical student. That's why
even medical students, Dr. Upendra, even 18-year-old medical students. Yeah, that's how we respond. What makes sense?
This is what I tell my son.
Yes.
Because I had a cardiac event, my father had one, my brother had one. I told my son, कभी दारू पी लेना, smoking मत करना. मैंने 35,000 पी के छोड़ी है, लेकिन I have had the consequences, and he has agreed to it. Till now, touchwood, is not smoking, and he shares everything with me because I always I've been talking to Deshpande Madam, Sangeeta Joshi is here. We are very good friends. We always talk. The most important thing in any counseling, whether it is home or the counselor and counselee, is the dialogue. Both should have a chance to speak. Unless you listen to him, you are not going to get results. So with this, I think we are getting late. We'll take some questions. Deshpande Madam has told me to take the questions, and I think Kavita and Shilpa can help me. I see chat box is not opening.
Sure,
There
sir.
is some issue.
So chat box is open.
Open, yeah. Let me go up. Yes, yes. Just a minute. There was one question by Sangeeta Joshi. Can you please explain more about exceptional situation? The question is to Dr. Sreyoshi if she is around.
Yes, so the exception situation is basically when a point during in the client's life when the problem may not have been happening or they were able to tackle the problem. So basically to help them identify such moments, such situations, how did they deal with issues at that time? How did they overcome them? So to really zoom in on that, to give them a sense of empowerment, over the problem. So to kind of focus on when they were able to tackle it or when it was not present. So it's the exception to the usual narrative.
Okay.
Sreyoshi, do you also ask, how did you feel when this problem was not there? Or when you didn't smoke, how did you really enjoy yourself? Would you also include this in the exception instance?
Yes, and I think also when we form the sort of the decision matrix, which is a part of MI, right? Then that there definitely this would get plugged in. So in the pros of how you felt when you were not engaging in those problem behaviors. So definitely as a part of it, but I think more when we are looking at the MI part of it, maybe it's like clearly described as a part of that.
There is a question from Dr. Khurana. Many therapists ask the clients to write their experience in a journal for analysis of problem so that positive solutions are derived. Your expert views.
So journaling comes in many different forms, many different shapes and sizes. So if it's a part of traditional CBT, it may come across as a bit prescriptive. Like if we insist that they have to maintain a thought diary and they have to sort of talk about when in the day they experience difficult emotions, what did they think, and try to look at alternative ways of thinking. But if it is collaborative, if we ask the client whether journaling is something they already do, whether writing and journaling is an area of strength for them, then that can definitely be built on and it can be used as a therapeutic strategy.
I think Kavita has already told that we'll be talking about the drugs in a separate session, so I'm leaving those questions. There's a pertinent question. What if the adolescent doesn't want to come to the counselor? How to bring him?
So many a times they haven't come, and we have just worked with the parents, with the family system. There is a lot that one can understand about the family system just from the parents, right? What have they been doing to tackle the problem with the adolescent? What are the kind of approaches they are using? So it has happened, especially adolescents with behavioral issues. For 2 or 3 years, I never met the boy. It was just the parents who would come, but then the improvements happen through them.
How can you help the adolescent identify strengths if they seem not to feel they have any, even after they are pointed out to them?
Yeah, so I think there it's also important to look at, like, if we are trying to highlight strengths, what is the impact it is having on this individual? Because a lot of adolescents really can't take compliments. They cannot identify their strengths. So if we see that, it's not landing well on them, we can actually point that out. And, again, the focus comes back to the therapist-client relationship. I'm pointing this out about you. This is something that has been highlighted as a positive attribute, as a compliment, but I feel like you're not being able to take it. You're not being able to hear me. Can we talk about what's happening right now? Like, what was going on in your mind when I was trying to highlight this positive attribute? So we can make it very relational, bring it back to the clinician-client relationship, and then explore from there.
And so the second part of the question was, are there family games or activities one can recommend to create a more supportive environment for the adolescent and family to build a better communication and rapport?
Well, as part of like the family therapy models, I mean, essentially just we look at whether this family has rituals that work for them. Like, what is the time that they spend together that they find meaningful and enjoyable? Again, it is not prescriptive like activities that we prescribe, but we look at what they may already be doing, or we look at what they were doing, or what their life and family rituals were like at a point when the family functioning was good, at a point when people were happy. So if we kind of make them reflect, there's a higher chance that they will bring about those changes rather than us suggesting activities.
There is a question from Dr. Latika about a child who is 9 years, had come with nighttime babbling as well as enuresis, which has been there for 6 weeks. No recent trauma and no family history of any change in dynamics. Cheerful child, but looks definitely something is disturbing. How do we approach this child?
So again, for such young children, very often their problems are rooted in family dynamics. So on the one hand, it just may just be like a slight delay in the developmental trajectory. So even normally we have 1% of 15-year-olds who may be anuretic at night. So I think just some reassurances and looking at how much the attachment issues and all of that are really perhaps perpetuating the problem. Often parents are very anxious. They may be punitive. They may respond quite negatively if the child is bedwetting. So often addressing these issues will take off that overlay of anxiety that may be perpetuating the problem. So it may be the same family dynamics, but the dynamics may have been problematic right from the get-go. So in young children, the focus is very strongly on looking at the family system and family dynamics.
And what are the prospects or limitations of online one-to-one counseling session?
Yeah, online sessions work well. I have found for kids who are at least 12 or 13 years and who don't have any attentional issues or ADHD. So if younger children and those who have ADHD, I have not found it really works well.
And there is a question from Dr. Atul Kanitkar. How does a counselor change the guilt within the counselee to a regret, and how to avoid dropouts and assess positive change?
I think Swati ma'am has addressed that bit very well. So if we just dial back to the guilt that this adolescent was experiencing, right, and that guilt, shame, and that relapse cycle, I think she just addressed it very beautifully. I don't think I need to add on to that.
I think this is the same question, how to deal with the deep-seated shame which caused the self-punishment. I think that goes the same. Please give more details about the decisional grid. This is by question by Sushma Kirtani.
I think that is moving into MI.
Yes.
Okay.
Maybe Swati ma'am might want to take that.
So in the decision grid, we just make a chart. And on one hand, there are pros and cons of the status quo, that he is comfortable, he is with his friends, he enjoys whatever he is doing. And in the next step, there is the do's and like pros and cons of the change behavior. Like if he quits or if he reduces on smoking, what happens? He will be a better player. Probably he will make his team win in the matches. So this type of and what I do in my practice is I assign plus or some stars. So how important it is. So winning a match for my team is important. So he will give 5 pluses to that. And then we count the plus and minus of both the pros and cons of the status quo and of the change behavior. And then it automatically happens that the change behavior scores more. And then the decisional grid is like the adolescent is convinced that yes, this change is worth considering.
Kavita, you want to continue or we continue the answers on the group now?
We can now continue answers on the group, sir.
Okay.
I think we should conclude now. It's already over time.
Yeah.
Yeah.
So thank you very much. Over to Kavita for.
Thank you, sir. Good evening, everyone. Good evening, esteemed members and honored guests. As we draw this insightful session to close, I would like to extend my heartfelt gratitude to everyone present here who made this event possible and successful. We had attendance of 172. And still till the end, we had more than 100 attendants left till the end. Our effort behind this entire endeavor is to prime and sensitize our audience with the basic tips of counseling. Some of the colleagues have messaged that one counseling sessions like this cannot train everyone, but that is true. But counseling tips are trained by every patient is a teacher for you. So with skills and with practice, you keep on learning. This is the just basic priming of everyone. So with this, I would like to invite respected Dr. Geeta Patil, madam, to please give your feedback that our endeavor is going on the right track or not.
Thank you, Dr. Kavita. But I think what Swati Ghate madam presented, she presented and then enacted. That is the right way of counseling skill to be developed. And I think each counseling session should have end with how Dr. Swati Ghate has done it. So the ideas will be clear definitely. And she has brought out all important points of the motivational interviewing. And maybe this is the way the presentation of all the counseling, if it goes on, counseling sessions, maybe it will be helpful in short period also. Now, I definitely understood motivational interviewing is definitely difficult, time consuming, and may not be possible everywhere. She has explained the limitations. So once she has explained the limitations, we will not apply where it is not to be done. And that is the right way. And Sreyoshi Ghosh, madam, I want to ask one question. Do overconfidence of the adolescent comes in a way of strength-based counseling, and how to analyze during that time? Because sometimes it causes a challenge for us. And Swati, congratulations. I don't need to tell you anything. You may be a model presentation for everyone. Thank you very much, Kavita. I think
Thank you so
just
much,
one small
madam.
question, Kavita. Kavita,
Yes,
I just
yes.
want to know
Yes.
overconfidence of the adolescent is the strengths, own strengths.
Ma'am, your voice is breaking, ma'am.
Are you able to hear now?
Yes, yes, ma'am. Yes, ma'am.
Okay, Shreyoshi, I was just asking overconfidence of the adolescent to assess the own strength. Does it come in our way, and how to overcome it?
Dr. Swati, ma'am. Dr.
Can
Swati,
I-
ma'am, please answer. Dr.
Kavita, ma'am,
Swati.
I
Is there?
think it was addressed to me.
Yes, yes. Yes, Sreyoshi, go ahead. Go ahead.
Okay. Yeah, so no, it does happen. Like especially sometimes children with externalizing problems, they will come and say that, everything is absolutely fine. I'm managing everything. My parents are making a big deal out of nothing. I'm great at everything. Usually it's kids with externalizing problems who come, with that sort of presentation. I think there also, like we do in MI, we can kind of roll with resistance, because obviously when we're looking at, so it's kids with externalizing problems like ADHD frequently who also have behavioral issues that develop, right? Whether it's behavioral addictions or whether it's substance use. So there, I think also, we can look at it as that they are at a very sort of pre-contemplation stage when it comes to their desire to really change. And I think we can sort of start from there, roll with resistance, understand them a little bit better. And if we're still not getting anywhere, it may help to actually have joint sessions or family sessions so that the family can gently then kind of introduce the agenda for us. If we're not getting anywhere with one-to-one, I found that it helps to work with the family system. And then we get a lot more information also about what is
Thank you,
going
Dr.
on.
Shreyoshi. I think we are running short of the time. Maybe you brought out the family involvement in the counseling session may be required in these type of cases. Thank you, Dr.
Yeah,
Kavita.
yeah.
I think we are running
ma'am.
short of time. And you have done a great job. I think we all will be waiting after 15 minutes. Thank you, Dr. Preeti Madam, for arranging these excellent talks. Thank you very much.
Thank you.
Thank
Thank
you,
you,
ma'am.
everyone.
Thank you.
Thank you so much.
Thank you, ma'am. Thank you for your kind words. I request Dr. Respected Dapke sir to please say a few words. Dapke sir, respected Dapke sir, to please give your feedback.
Very difficult problem for me. I have gone through 200 papers on this subject. And it was a brainwashing for me. And what I thought, most of the interventions and that we are planning and doing are probably following the Western way of thinking, Western culture, Western way of working. And our society today is a mixture of, I don't know, partly we are having Western way of working, partly we are having some Indian thinking, and this has created more problems in our adolescence. What I thought, there are 190 articles on adolescent therapy by meditation therapy. And it would be a very simple way, because if you go to किसी कथा वथा में जाएंगे तो we don't see any adolescent. We don't see any mother and father who are younger, is 30, 40, 50 years. We only see persons who are 50 plus, old persons. In a city of Raipur with 15 lakh population, in a very important sort of gathering, only less than 200, 300 attendants are there, which sees probably your way of thinking. What I thought, if parents, mother and father both, along with their maybe 2-year onward child, at least take to place of meditation twice a week, regularly, probably so many problems which we are facing may be postponed, may be delayed, and some may be avoided also. But if what this is not we are following, we are neither 100% Western thinkers. Our mother, father have no time to spend with child. They have to start leaving home at 8 o'clock after their work, and father comes at 8 or 9 o'clock, 10 o'clock home. And this is some cause for the problems which you are facing in our adolescent. So what I thought, this what you call meditation, which is intervention for so many other intervention with Professor Nair, Ankit Nair has already discussed, and there are hundreds of articles on this. So I think if we have one small session on this also, probably our way of may be more easier for us. And this sounds easy, but in practice, it may be very difficult for them. So, but I thought a little thinking should be. And last thing which I thought, no mention has been, there are two interventions which, if very young parents have a child, a father above 50 have a child, there is high risk of psychiatric behavior. And we are 10 years, more than 10 years behind what Western are doing all this problem. And this is what all these cases we are doing, they are now doing complete genome analysis, which is a costly affair. But now there are about 10 or 20 small what you call genes, factors which have been isolated, and if they are corrected, probably the severity of this problem may be in years to come. And this is a regular process. Probably we are not in a position to afford this because these tests are very difficult, and if not done correctly, they are only adding to confusions in most of cases. So I would suggest Madam from NIMHANS, and they can take up this problem also. And lastly, which I thought, since Madam is from CHATTISGARH, I have worked there with CHATTISGARH. The problem in CHATTISGARH is much the discussions which I have seen, the treatments which I have seen, they are upper middle, higher middle class, upper class population. We have not discussed the psychiatric problems of a street children, very poor children, and plus 30 to 40% of population of Chhattisgarh is tribal, where they are living, where they are coming, and how they are being reared up. They are so difficult things. Probably it is high time that we start solutions for them also. Again, I express my gratitude to all the learned, very learned speakers. I have not wasted half a minute of this last times and this time's lecture. I am grateful to them. And of course, the organizers, I think they are doing very good job. Once again, thank you all. Thank you.
Thank you, sir. Thank you. आपके जो guidance है और आपके जो advices हैं, they are well taken, sir. You are always a teacher for us. Sir. Thank you. Thanks a lot. And now I would request CG President Dr. Kiran Makhija, sir, please say a few words. Dr. Kiran Makhija, sir, are you there? I think he's not there. I request Dr. Preeti Galgali, madam. Shilpa, he's there. Kiran sir is not there.
Arun Agrawala sir is here.
Yeah.
Kiran sir is not.
I request CG Secretary Dr. Arun Agrawala sir to please say a few words. Dr. Arun, please unmute yourself.
I think it's not there. We can conclude. Hand over to Madam Galgali Madam to Vachan.
Galgali ma'am, I request Dr. Preeti ma'am to please conclude the session.
Thank you so much, Kavita. Wonderful sessions once again, Sreyoshi and Swati. And thank you, Dr. Arun, for very, very valid points. I'd just like to share in the last session, we did share a few websites for mindfulness, meditation, and the yoga modules of NIMHANS. NIMHANS is doing a lot of research. They have a department of integrative medicine, and there is a lot of research which is there, a very good connection between the allopathic and also Ayurveda and yoga. And I'll be happy to share a few articles on that. On another note, you know, the heads, we talked about heads last time. It is slowly being replaced by shades. And I will be posting a few articles on the group. So S stands for strengths. And there is a lot of research now going on that probably shades is better than heads, where we start with strengths. So on that note, thank you very much. And I'll be looking forward to more interaction on the group. Thank you so much.
Thank you, ma'am. Thank you. Thank you. Opinions and feedbacks of our respected seniors is the motivational power behind our entire endeavor. With this note, I wish to pay my special thanks to all the esteemed speakers, Dr. Sreyoshi Ghosh and Dr. Swati Ghate ma'am, for very impressive and lucid talk, especially that conversation wala session was really no words to for that session. It was really wonderful. That was really wonderful. And I'm really sure that our audience also have enjoyed that, because the strength of the audience is the power of our feed. This is the feedback. And with our sincere thanks to our chairpersons, Dr. Madhushri madam and Dr. Ashok Mehta sir, for your adept guidance and for steering today's discussion with such expertise and dedication. I pay my I'm really deeply honored by the presence of our special guest, Dr. Yogesh Parikh sir couldn't join because of his trip, he is on the airport, but I'm really thankful to him, and I'm thankful to Dr. Upen sir. He has joined till the end. So it is really our strength. Thank you, sir. Thank you for your presence. And I'm deeply thankful to CIAP President Dr. J.V. Basavaraja sir, CIAP President-elect Dr. Vasant Khalatkar sir, CAHA Chairperson Dr. Geeta Patil madam, CAHA Secretary Dr. Prakash Veer Arya sir, CHA President Chairperson-elect Dr. Hima Bindu ma'am, Dr. Shalini Vasan ma'am, EB Central Zone, and Dr. CGAP President Dr. Kiran Makhija sir, Secretary Dr. Arun Agarwala sir, and all the office bearers and respected seniors. I'm really thankful to all of you for your support and guidance always. My special
And
thanks
if I may
goes-
add, Kavita, Dr. M.K.C. Nair sir in
Yes,
absentia.
I'm
He's
coming.
main force. Yeah.
My special thanks goes to Dr. M.K.C. Nair sir and Dr. Preeti madam, who are the backbone of this entire program.
Yes.
And thank
Dr.
you all the
Prakash ji booked
attendees
3
for your
days,
special participation.
Acha.
Yes. Thank
Yeah,
you
brought
all
it.
the attendees for your participation, especially on the Sunday evening, which is really appreciable. A special acknowledgement goes to my entire team of CGHA and the technical team of Zuventus for your hard work and meticulous planning and bringing this webinar a real success. And we look forward to our next session also after 15 days. I'm expecting more than the present attendance. Day by day, our attendance is increasing. So thank you everyone. And please forgive me if I miss any name. And because of the time restriction, I cannot call everyone. So just please forgive me for that. Thank you everyone. Thank you. Thank you
Thank
for
you.
the
Bye-bye.
wonderful
Special
session,
thanks to
successful session.
Special thanks to Dr. Preeti. You have chosen the topic and the presenter so nicely that excellent sessions are going on. My heartfelt thanks
Thank
to
you,
you.
ma'am.
Thank you, ma'am. Thank you.
Thank you.
And
Thank
thanks to
you.
everyone for joining there, especially on Sundays. Thank you, ma'am.
Thank you.
Thank you so
Thank
much.
you. Thank you.
Now you
Bye.
can leave.
Yes.
Thank you.